Good evening, everyone. My name is Allison Kate, and I'm a hand and upper extremity surgeon with Summit Orthopedics in Sibley Hospital. I'm going to speak tonight about some of the common conditions that I see in my practice that affect the hand and upper extremity. I'd like to thank the Gildehorn Institute for sponsoring this lecture series and let you know at the end of this lecture, I'm going to answer some questions. But instead of having people ask their questions in person, we ask you to go to the question and answer part of Zoom and type the questions there, and then I'll do the best I can to address them after the lecture. So let's talk about what are some of the reasons that your hand might hurt. One of the most common things that I hear in my office is that the hand feels numb and tingly. Patients will say that they wake up at night and they have to shake their hands out because their hands feel numb and they have pain traveling all the way up their arm. As the problem progresses, in addition to nighttime pain with numbness and tingling, patients also sometimes report that their fingers fall asleep while driving or talking on the phone or reading the newspaper or a book. As the problem gets even worse, sometimes they notice that they drop objects. This can be because of a very common problem that we're all aware of called carpal tunnel syndrome. Carpal tunnel syndrome is when the median nerve gets pinched in a tunnel located in the wrist right about here. That nerve gives sensation to the palmar surface of the thumb, index, middle, and half the ring finger. And it also gives strength to the muscles at the base of the thumb. This picture right here is a cross-sectional image taken from an MRI scan that shows the carpal tunnel. What you can see is that the median nerve, here shown in white, is surrounded by all these dark ovals, which are the flexor tendons that help type on a computer or grip a steering wheel or hold a book. Just to orient you, this is the palmar surface and this is the back of the hand. And here's the nerve and all the flexor tendons. This dark gray band where my arrow is the roof of the carpal tunnel. And it's a really taut, thick band of tissue that does not expand under pressure. These bones right here where my arrow is now are the small bones of the wrist, and those form the floor of the carpal tunnel. So we have a fixed roof and a fixed floor, neither of which expand under pressure. So when the pressure in the carpal tunnel goes up, because of swelling around the tendons from use of the computer or fluid retention states like pregnancy, there's nowhere for that pressure to go when the nerve gets pinched. When the nerve gets pinched, it manifests itself with pins and needles in the fingertips, numbness and tingling and pain up the arm. When that happens over time, again and again and again, the problem can progress to the point where the nerve gets damaged. When this happens, these fingers on the radial side of the hand can feel numb all the time, and the ring finger feels different on the thumb side than it does on the pinky side when the nerve gets damaged. As it gets even worse, in addition to having nerve damage that causes numbness in the fingers all the time, this muscle can start to atrophy at the base of the thumb. And if you look at this picture here of a patient's hand looking from the top-down view, you can see that the musculature at the base of the thumb is concave here from the atrophy instead of the normal convex appearance at the base of the thumb. So this is when we get end-stage carpal tunnel that's not been treated. So how do we treat carpal tunnel? How do we avoid that from happening? Well, when patients have early symptoms, so it's just nighttime wakening and no daytime symptoms, I typically start treatment with a night brace. And this is an example of a carpal tunnel brace that's designed to keep the wrist in a neutral position at night so we don't bend the wrist in a position that raises the pressure on that median nerve. I ask patients to wear the splint at night and not during the day, and sometimes we add this with some nerve gliding therapy exercises to help get rid of the inflammation in the hand. If this works to take care of the nighttime wakening and pins and needles, that's all we need to do for a period of time. But over time, carpal tunnel typically does get worse and progress, maybe years, but at some point, patients typically do progress to the point where they have daytime symptoms with numbness and tingling during the day as well as at night. And we don't like people having to wear a brace all day and night. And so then we go to the next step of treatment, which sometimes involves a cortisone injection. The cortisone injection for carpal tunnel works by trying to take away the inflammation around the nerve. It's a procedure that can be performed in the office, and it typically provides fairly quick relief from the nighttime awakening and the burning pain from carpal tunnel. However, 80% of patients get recurrence of symptoms within a year after a carpal tunnel injection. So it's typically just a temporizing measure and not the definitive treatment. It does help with diagnosing carpal tunnel because there's other reasons why the hand can feel numb and tingly. So if we put medicine in the carpal tunnel space and it resolves the problem, even temporarily, that's a good sign and diagnostic confirmation for us that the problem is coming from the carpal tunnel itself. So if we give an injection and patients get months of relief and the problem comes back, we don't like giving repeat cortisone injections for carpal tunnel because cortisone is not great for the tissues in repeated fashion. And so finally, if the problem persists, we proceed to definitive treatment for carpal tunnel, which is a minor surgical procedure called a carpal tunnel release. In this procedure, we make a small little incision in the palm and we open the roof of the tunnel to take the pressure off the nerve. The nighttime awakening usually goes away the night of surgery and typically never comes back. So it's usually a one and done phenomenon. The one issue with carpal tunnel surgery is that if we do the surgery when the symptoms are still come and go, and there's no numbness or weakness all the time, but just that pins and needles that comes and goes, we can almost guarantee a great relief with no problems with the nerve. I do hear patients often say that they had a friend or a neighbor that had a carpal tunnel surgery that didn't work. And while I don't know exactly what happened in that instance, often it's the case that the surgeon didn't do the best job explaining to the patient what the expectations are of surgery. So if you get a patient with severe carpal tunnel, which means in addition to the come and go tingly feeling, they also have numbness all the time in these fingers and weakness in their hand, that's a sign that the nerve has already been damaged. And when that happens, the goal of surgery is to prevent further nerve damage, further loss of sensation, and further weakness from developing, and to help with the nighttime awakening. While doing the surgery relieves the pressure from the nerve and gives the nerve the opportunity to recover, it's not guaranteed that the nerve can recover from the nerve damage that has occurred from long-standing carpal tunnel syndrome. And what we know is the younger you are and the shorter duration of symptoms you've had with a nerve, the less likely you're going to have irreversible nerve damage from carpal tunnel. But for that reason, this is one of the conditions that if you have numbness and tingling in your hand, it's a good time to see a hand surgeon, either me or one of my colleagues, and it's not something to ignore because it's very easily fixed if we address it promptly. But if we wait till there's nerve damage, it can be hard to make recovery. Now, the nerve can recover. Nerves can recover a millimeter a day, but it's just less predictable once you get to that stage. The surgery itself is a very minor surgical procedure. It's in and out the same day. You're in a soft bandage for about 4 days, and you can do light activity with your hand very quickly, like typing and writing. In my hands, I just ask patients not to do heavy lifting and gripping for about 4 to 6 weeks after surgery, while the roof of the tunnel that I open fills back in, just into a more stretched out position. Most people get great relief from their symptoms after carpal tunnel surgery, and it's such a minor surgery that most people don't need anything more than ibuprofen and Tylenol for pain afterwards. We can do it with either twilight anesthesia, which is light sedation, or we can even do it awake with just numbing medicine. So patients who don't want to fast for surgery or don't want any risks of sedation from anesthesia will do very well with just having local anesthetic for their carpal tunnel surgery. Now, another reason I see patients in the office is for numbness and tingling on the other side of the hand. So that's the small and the ring fingers. These patients often also note weakness in the hand, and they also get nighttime awakening, but they also complain of pain when they put their elbows down on hard objects like a car console or a kitchen table. When you get numbness on the outside of the hand and the pinky and the ulnar half of the ring finger, that's not because of carpal tunnel syndrome, but rather it's because of something called cubital tunnel syndrome. And this is when the ulnar nerve gets pinched around that funny bone, which the medical term for is called the medial epicondyle. The ulnar nerve is very vulnerable right there. So that's why when you bang the inside of your elbow, you get that kind of zinger feeling with pain into your pinky and ring finger. That's the ulnar nerve that gets damaged there. And when we sleep at night and we bend our elbow all the way up, you can see how the nerve would get traction around that bony bump on the inside of the elbow. And that can lead to nighttime tingling and numbness. This nerve gives all the intrinsic strength of the hand. So in addition to causing numbness and tingling in these two fingers when the ulnar nerve gets pinched, it can also cause weakness in the hand. And this is an extreme severe case. This is a patient of mine where if you look at both of her hands, on the left side, you can see that there is good muscle that's retained between fingers here. But if you look on this side, these valleys here are because of atrophy of the intrinsic muscles of the hand. And that causes weakness, trouble with grip, trouble with opening and closing the fingers. So that's a severe case if the nerve keeps getting pinched for the cubital tunnel syndrome over and over again. Treatment for cubital tunnel syndrome is similar to treatment for carpal tunnel syndrome, in that if you just have nighttime symptoms and it doesn't really bother you much during the day with no baseline numbness or weakness, we can treat the intermittent tingling at night by giving you a brace at night that prevents you from sleeping with your elbow all the way bent and prevents you from irritating that nerve. If that works well, we stay the course. But in patients who have daytime symptoms or progressive symptoms despite splints, we typically get a nerve test to confirm that the nerve is in fact pinched at the site of the elbow, and then consider surgical treatment to release the ulnar nerve at the elbow, and sometimes we move it in front of the bony bump. There are lots of spots at the elbow where the nerve can be pinched. You can see a tunnel here, here, and here. And so a good hand surgeon will go through and release every one of those spots through a small incision about the elbow when we treat cubital tunnel syndrome. Another common condition I see in my office is related to the finger getting stuck and to hand pain from this condition. Patients will report that their finger gets stuck in a bent position, most commonly when they wake up in the morning. And it can be quite painful when it gets stuck, but sometimes it's just annoying to them without a lot of pain. When it does hurt, they typically point to the area right here where the thumb is, the base of the finger, as the site of the worst pain. This condition is typically caused by something called a trigger finger. A trigger finger is when the tendon that helps you make a fist gets stuck in the tunnel that it runs in. This is a diagram that shows that. So this is a side view of your finger. And here you can see the white structures are the bones, and this dark gray structure is the tendon that you use to make a fist. The tendon is held close to the bones by these series of light gray structures called pulleys. And I like you to think of the pulleys like the loops on your pants that hold your belt in place. They hold the tendon in place to the bone. When you have a trigger finger, the pulley at the base of your finger right here, called the A1 pulley, gets thickened and inflamed just from use. We don't know why this happens to some people, just use can make it happen. And then as you bend and straighten your finger, the friction of the tendon passing underneath that inflamed pulley causes the tendon to form a bump or a nodule on it. It's reactive from passing underneath that inflamed pulley. Back to our belt analogy, this is like your belt has a knot in it. And when you squeeze your hands tight, the knot's stuck on one side of that inflamed pulley, and then you have to force it through the pulley system when you straighten it. And that can cause pain and catching depending on how big the nodule is. Treatment options for trigger finger include a variety and a spectrum depending on the severity. If it doesn't really hurt much and it's very mild and just occasionally at night, sometimes we start with a splint that you wear just at night. I will tell you though that I'm not a huge fan of splinting for trigger finger, because one of the most common downsides of an untreated trigger finger is finger stiffness, because people don't like their finger to get stuck, and so they voluntarily restrict motion in the finger, and that can lead to stiffness that's harder to treat than the trigger finger itself. So nighttime splinting is okay, but I don't recommend splinting during the day. And if the problem persists, we move to a cortisone injection. Unlike the cortisone injection for carpal tunnel syndrome, the cortisone injection for trigger finger can actually be curative. So 50% of patients can be cured with one cortisone injection. And in this case, it's designed to take away the inflammation around the pulley so that the tendon can pass without getting stuck. We do this in the office, and usually within 1 to 2 weeks, people notice a vast improvement in terms of their pain and the catching of the digit. If it provides sustained relief, and they're one of those 50% that the problem goes away and doesn't come back, they go about their lives and don't need to follow up. But if the problem persists, we can either do a second injection or move on to definitive treatment. I don't recommend more than 2 cortisone injections for any specific trigger finger, ever, because too much cortisone is not good for the soft tissues and can lead to problems with the tendon if it keeps having cortisone over and over again. So if the problem persists after 2 injections, typically we move on to surgical treatment. The surgery for trigger finger is a very minor surgical procedure. I make a small incision over where that pulley is and just open the pulley so the tendon can pass. Often we do this with patients wide awake, which means we numb up the area and there's a drape up so you don't see any surgery, but you can eat and drink and drive yourself home from the surgery and participate in the surgery. So once I open the pulley, I can open and close and make sure that there's no catching anymore. Similar to carpal tunnel, patients go home with a soft bandage on their hand, and it's only on for a few days. And they can do light activity right away, like typing or writing and swiping, but no heavy lifting or gripping for about 2 weeks till the wound heals. For patients who don't like the idea of being awake for surgery, we can also do this with twilight anesthesia, but either way, you're completely breathing on your own. You just don't remember the experience if you have the sedation, kind of like a colonoscopy. It's a very minor surgical procedure, and it is the definitive treatment. Another problem that I see a lot of in my office is pain at the base of the thumb. This is often also associated with weakness with pinch and grip. So people will report pain and weakness and trouble opening water bottles or turning keys or writing or pulling the lid off of a yogurt. The pain is typically reported right in this area here at the base of the thumb, and it's from arthritis at the base of the thumb. So this is an x-ray showing that, and what I'd like you to focus on is the space where my arrow is right here between these 2 bones. So this space represents the amount of cartilage that is left, that smooth white cap on the end of the chicken bone that prevents bone from grinding on bone at this space. We don't see cartilage on x-ray, but if there's preservation of a symmetric dark space between the 2 bones where a joint is, that means that the cartilage still remains at that location. But if we move one joint towards the thumb at the base here, you can see that the dark space is pretty much obliterated here. There is no joint space left. And all this white tissue here, this angry white bone, is because the bone right adjacent to the joint is seeing a lot of extra stress without that smooth, soft cartilage cap remaining. The other thing you see here is bone spur formation. And that's basically the body's reaction to arthritis, where the body tries to form a lot of extra bone to almost fuse the joint so it won't grind and move so much anymore. So this patient has bad arthritis at the base of the thumb. Treatment follows a very similar algorithm to some of the other diagnoses we've discussed so far. At the most conservative level, wearing a brace can provide a fair amount of relief. The brace works by supporting the joint and preventing as much bone grinding on bone when you're doing functional activities. It can also calm down some inflammation at the joint if you've overdone it. Typically, for conservative treatment, we give you a brace, and we consider anti-inflammatory creams like arnica gel, which is a plant-based anti-inflammatory cream, or Voltaren gel, which you may have heard of, which is now over the counter, which is kind of like topical Advil. If that works well, we stay the course, but in patients that have pain that's beyond the relief that a brace can provide, we give a cortisone injection. And the cortisone injection for base of thumb arthritis is not going to cure it. It does not put cartilage back where cartilage is gone. But what it does do is handle the inflammatory response from the arthritis that causes spikes of pain. So what we notice with arthritis is that there's some component of pain from bone grinding on bone, and there's some component of pain where you just get a lot of warmth and swelling and inflammation, and the cortisone works great for that, but it just doesn't help so much when it's just bone grinding on bone pain. But I have some patients that get months and months of relief from cortisone injections, and if it works, we keep doing it until it stops working. But at some point it does stop working, and if patients don't get a minimum of 3 to 6 months of relief from a cortisone injection, there is a surgical procedure that can cure the pain from the base of the thumb arthritis. So back to our preoperative picture here, you see that there's a lot of bone on bone right here with big bone spur. And this is after a surgical procedure where we remove the arthritis in the arthritic area at the base of the thumb. And the way I do this, I also do a small little tendon transfer right here, all through the same incision to support the thumb so that this bone doesn't go down and touch this bone anymore. In my hands, this is an outpatient surgical procedure that takes about an hour. I do it with a regional nerve block and sedation, so I don't typically need general anesthetic. And patients go home with their thumbs splinted, but these fingers are all free so they can do light activity like typing and swiping, no lifting. The thumb is immobilized for about 6 weeks after surgery, but the majority of that time is in a removable plastic splint that a patient can remove for showers and hand hygiene. A lot of other hand surgeons do this with a different technique that requires casting and pins, and so you may have heard from friends that had a really long recovery from this. But the way I do it, it's no pins, no cast, just a splint after surgery for 10 days and then a removable plastic splint followed by a course of hand therapy that starts around 6 weeks with the goal of regaining motion and strength. Most people get really good pain relief from this surgery, and they're some of my happiest patients. I love this surgery because we can pretty predictably restore the ability to pinch and write and open water bottles without pain. I tell patients I can't give you the thumb you had when you were 20 because I'm altering the anatomy of your thumb, but I can give you a thumb that doesn't hurt every day. And by and large, most people are very pleased with it. Finally, I'm going to spend just the last few moments talking about ganglion cysts of both the finger and the wrist. So a lot of people present with a bump on the back of the finger. And this bump here is called a mucoid cyst. It's a fluid-filled cyst that emanates from an arthritic joint below. And essentially, joint fluid leaks out. And because it communicates with the joint below, it tends to fluctuate in size. So there's days it's bigger and days it's smaller. Typically doesn't hurt that much unless you bang it on something, but there's often some underlying aching from the arthritis that caused it. Occasionally there will be a nail ridge associated with it because of the pressure the cyst puts on the male matrix underneath. Treatment options for ganglion cysts of the finger and wrist, and this is one of the wrists that comes from the joint below here, are very similar. We can either observe them. In the wrist, we observe it with a wrist brace to try to encourage the fluid to go down. And the finger, sometimes we splint or wrap it to try to encourage the fluid to go down. But observation is fine if it doesn't cause too much pain or discomfort. If they are symptomatic, and sometimes they are, we can either remove the fluid in our office by aspirating the cyst or surgically remove them. Aspiration has almost 100% chance of coming back because you're taking the fluid out from the top, but not stopping the leakage of fluid from the joint below that fills up the cyst. But it can be a temporizing measure, like if you have a wedding to go to and you've got this big bump on the back of your wrist. I've had patients ask for it to be drained before a procedure like that, knowing that it's going to come back. The definitive treatment is to surgically remove the cyst, either on the wrist or the hand, through an outpatient procedure. And while the recurrence rate is nowhere near 100%, it's not zero, but most patients do very well with that procedure. So that's all the time we have now to go over some of these basic conditions. I'm going to go through the Q&A session now and see if there's any questions I can answer for you. But if you do have any specific questions about your own issues, please feel free to give my office a call. Again, I'm with Summit Orthopedics, and my phone number is 301-657-9876. And my office is just around the corner from Sibley on New Mexico Avenue, and I'd be very happy to see you and take care of you if you have any questions. So let's take a look here. Okay, one of the first questions I have is what type of imaging should be done before surgery for trigger finger? And how long after surgery do you typically have to wait before you can use a computer? So no imaging needs to be done for a trigger finger. You do need to have a hand surgeon look at you and make sure the diagnosis is correct, but it's not the type of surgery that needs any MRI or X-ray or ultrasound imaging in the vast majority of patients. And as far as using the computer afterwards, essentially right away. So I typically tell people, the more you rest in the first few days after surgery like this, the less bleeding, swelling, and scar tissue you have, and the more likely you are to have a very quick and uneventful recovery. And so I typically operate on Thursdays, and I say rest through the weekend. But by Monday, if you don't have any pain and you don't need ibuprofen or Tylenol to mask your pain. Go ahead and type and write and do anything that doesn't hurt. Just don't do things that hurt, because that's a sign that you might be overdoing it. But light typing on a computer can be done right away as long as there's no pain. Another question I have is, what do you recommend if a second cortisone shot for trigger finger improves the condition significantly but not 100%? So that's a good question. It depends how much the pain and triggering is bothering you. So if you have absolutely full motion, because remember I mentioned stiffness can be a problem after a trigger finger, but if you have absolutely full motion and the pain's not horrible, maybe it's a little bit sore but not bad, I recommend watching and waiting and see how you do. And I don't recommend a third injection, but if the problem gets worse again, that's when you would consider proceeding with surgical treatment. Okay, I have another question about having a lot of pain and stiffness at night. Sometimes that can be because of numbness and tingling, and sometimes that can be because of arthritis pain. So arthritis pain typically bothers us a lot at night, either at the end of the day or in the morning. At the end of the day, tends to be more sharp pain. In the morning, tends to be achiness and stiffness. And it typically responds well to heat, like Epsom salts with a warm bath can help get the fingers going. But if you are having a lot of sharp pain and it's becoming quite bothersome and trouble with stiffness, I do recommend calling and coming in so we can evaluate your hands. All right, next question. How long does it take for the ulnar nerve to return to function after cubital tunnel release with and without transposition? So this question is about that cubital tunnel syndrome we talked about, the pinched nerve at the elbow, and transposition is when we move the nerve in front. And the answer depends on how severely the nerve has been damaged. So if the nerve has just been pinched and there's no baseline numbness and no weakness in the hand, recovery is very quick. So the tingling goes away right away and people feel great and they have no issues. The surgical recovery for that surgery is about 2 weeks in a sling, and then work on regaining motion and strength afterwards. But the recovery is very quick. If the nerve has been damaged, nerves typically recover 1 millimeter a day. So to get from your elbow all the way to the tip of your finger takes months and months and months. So it's about 6 months. Transposition sometimes can actually slow down recovery a little bit, because by moving the nerve, there's a little bit more manipulation around the nerve. Sometimes it can facilitate recovery. So really it depends on what the nerve looks like when we do surgery about whether or not we should transpose the nerve. But it doesn't necessarily change that timing that much. So it's about 1 millimeter a day. The next question is about recovery also for ulnar nerve surgery. So I mentioned that briefly, but for my patients, they're in a sling for 2 weeks to avoid repetitive elbow motion. And then afterwards, they work on motion and strength. And by 6 weeks, most people are back to full activity. Another question here is about pain from texting with the thumb. That can be for many different reasons. It can just be from tendinitis from overuse. It can be from a trigger thumb. So just like the trigger fingers can affect any fingers, they can also affect the thumb. And that's usually causes pain right here at the base of the thumb when a trigger affects the thumb. And sometimes it's from arthritis and overuse from texting. But a lot of times, modification of activity, like a different phone or a different position for texting, or using the microphone when you text, can help minimize that pain. And sometimes we have you see our hand therapist to help you modify and identify behaviors that can be changed to help minimize pain from that. All right, another question is about tendinitis in the wrist and problems with ulnar side of wrist pain, so pain over here, and whether it has anything to do with having the nerve released at the elbow. And the answer is they are a different condition and not related. So it shouldn't develop or worsen afterwards. That's just bad luck. Okay. I like this question a lot. This is, how do you control the pain from a hand injection? Because the injections hurt a lot. And I actually have spent an enormous amount of time in my practice doing everything I can to try to minimize pain from hand injections, because I hear you and I hear my patients, and they really can hurt. So the way that I do this is multifactorial. So first, I ask patients to try to relax their hand, particularly for a trigger finger injection. When you try to straighten your hand and you give less space for the injection to go into, it tends to hurt more. So I ask my patients to relax their fingers before I give the injection. Second, I'll use the cold spray to try to dull the initial poke from the needle. And then I use a much smaller needle than many orthopedic surgeons use, which helps really minimize the pain from the injection. And I go slow with the injection. So if you force fluid in the area quickly, it tends to hurt a lot more. So there's several different techniques that I do to try to minimize the pain from injections, but I can't eliminate it altogether. Okay, there's a question about magnesium sulfate. I don't really have an answer about that. I would talk to your primary care and see what their thoughts are on that. Okay. So, another question is about how you know whether hand pain isn't referred from the shoulder or neck. So sometimes you can get pain from a pinched nerve in your neck that causes burning or pain radiating down from the neck all the way into the hand. And there's different ways that we can tell that. One way you can tell that is if you put your hand up over your head and the tingling or pain into your hand goes away, that can be an indication that the source is actually your neck and not your hand. The reason that happens is because the cervical nerve roots get traction when your arm's down by your side. But if you put your hand up over your head, you take the pressure off those nerve roots. And then if that makes you feel better, or if the pain's worse when you move your neck in certain positions, it's probably more coming from your neck than your hand. But the other answer is that your surgeon will do a good physical exam and check all the areas and get a better sense of it. But there are also diagnostic tests like nerve conduction studies and imaging studies that can help us determine the site of nerve issues and the source of the pain. And then finally, there's some other questions here that are more personal about specific issues going on. And I would encourage you to make an appointment, be happy to take a look and see if I can help. Or I also have lots of very good qualified hand surgeon colleagues that are also affiliated with Sibley that I would ask you to take a look and see. So with that, I will thank everybody for joining us at this webinar. And again, my office number is 301-657-9876. And I'd be very happy to take a look at any of your personal issues. Thank you and have a good night.